All right, in this video, I'm going to teach you how to hook up the patient monitor, the anesthesia monitor, to a patient. So my patient is already intubated, and I've got him hooked up to a rebreather right here. Sometimes there's an order to how you hook things up. It depends on your hospital's practices. What I usually do is when they first come in the room, this would already be hooked up. This is a capnograph. The way that it works is this clear line connects here. There's a small clear connector here that it screws onto. And then this goes between the endotracheal tube and the breathing circuit. So a lot of times before we even come in the room, we'll have that hooked onto the breathing circuit. So when we put down the patient, we plug him into the breathing circuit, that's already on. So the capnometer records the amount of CO2, carbon dioxide, going into and out of your patient. If you see over here, the inspiratory CO2 should be between 5 and 10 millimeters of mercury, mmHg. The end tidal, T-I-D-A-L, tide like the tides, the end tidal CO2 should be between 35 and 45 millimeters of mercury. It also monitors their respiratory rate here because they're breathing in and out, so why not? So that's the capnograph. Connects between the endotracheal tube and the breathing circuit. The next piece that I typically put on is this one. This is the SpO2 monitor, sometimes called the pulse oximeter or the pulse ox. The connections on this machine are pretty straightforward. There's only one place that this can go. Then there's ones here for the temperature. They're labeled here for blood pressure, heart rate, non-invasive blood pressure, and so on. So I'm going to plug this one in and watch on the monitor what happens when I do. You're going to see it pop up right there now that I've plugged it in. So this monitor measures the amount of oxygen in their blood. The most common place to connect this is the one, you've seen this at the doctor's office with the red light they put on your finger. We typically put it on their tongue. We can put it in other locations as well. This connector works really well between the toes. So you put it on that webbing between their toes and that will measure as well. And this one can go rectum. It has two little lights on it. That one goes in the rectum. Other places we can connect it. Like I said, we kind of default to their tongue. We could connect it to their lip, to their ear, between the toes, in the rectum, or on the vulva or the prepuce if it's a female or a male. So I typically put that one on next because it just takes a second to hook on. And the SpO2 shows you the amount of oxygen that they're getting, or the amount of oxygen in their blood is expressed in percent. You never want that one to drop below 96%. So 96, 97, 98, 99, 100 makes us happy. Anything below that, we need to assess what's going on. So if things were to go below that, any of these things were to be off of what we want them to be, first thing you do is check your patient, because maybe that's real reading. So check your patient first, make sure they're okay. To check for this one, I would check mucous membrane color and capillary refill time. If everything seems fine, he's in a good plane of anesthesia, he's stable, now I'm gonna look at my monitor and say, well, what could be going on that this isn't reading right? Some of the things that could be wrong, sometimes the tongue gets cold or dry. So if this was the tongue, I just kind of massage it like that, just real briefly, bring some blood flow back to it. You can also wet with just some tap water, wet some gauze or something and drip it on there, put your probe back on, and it should work. If it doesn't, maybe try one of the other locations. So that's the pulse oximeter. Another monitor that we have is the EKG. This is the electrocardiogram. This one, it says right here, ECG. It's the only one that this would plug into. It's got its name there. This is a black connection, that's a black connection. So that's the only one it'll plug into. Now it's gonna start trying to read. I have 3 leads on this one. Some have 4, some have 5, some even have 12 if you work at a cardiology center. But with this one, the leads go in specific places. So I have a red, black, and white. So there's kind of a little rhyme that you can use to help remember where they go. So the white goes on the right. This is gonna go in the axillary area, so where like in the armpit. So I'm gonna make sure that I'm grabbing skin and not just fur, and I'm gonna connect that there. And I've had people say, well, don't those clips hurt? I'm sure they do, but they're under anesthesia, they're getting a lot of pain medications, and we're doing surgery, so these are gonna be the least of their pain. So white goes on right, the opposite of white is black, and the opposite of right is left. So black goes on the left one. That leaves my red. The black is like smoke, the red is like fire. So smoke rises over fire. So the red one then would go in the left inguinal area. That's like the webbing between their leg and their body. Making sure I get skin and not just fur. If there was a fourth one, it would be green and it would go in the right inguinal area. A couple of other tricks you can use to help you remember that. The two in the front are black and white. So black and white like a newspaper. Newspaper comes in the morning. The other two are red and green like Christmas. Christmas comes at the end of the year. So that's how you can make sure that you've got your probes hooked on right. I don't know if you've ever watched Grey's Anatomy, but in the pilot episode, Meredith Grey is hooking an EKG onto a patient. You hear Bailey in the background going, smoke over fire, Grey. That's what she's talking about. Now this part, the connection where all these wires come into, this can be pretty heavy. And you don't want to just drop on the floor and yank on their skin. There's a little clippy on here. So they'll be laying on a towel typically. So you can clip that to the towel so it doesn't fall off. Next, I'm going to put on the blood pressure. This is non-invasive blood pressure, NIBP. So the first thing I need to do is measure for my cuff. I have lots of different sizes. The way that I measure for this is I take the short side of this and put it against wherever I want to place it and see. It should measure 30 to 50% of the way around the leg. So I'm going to measure him 30 to 50%. Looks good, so I'm going to place it there. Now you can put it either between the elbow and the wrist, elbow and carpus, or you can put it between the stifle and the hock, the knee and the ankle. I'm going to do between the stifle and the hock because I've already got a lot going on up here and I'm going to have IV fluids running, so I'm going to put it back here. I'm going to need to adjust my ties just a little bit so that I'm not clamping down around this blood pressure cuff. This one says this side to patient, so that's the side that needs to touch his skin. So I'm going to put this on, making sure it's nice and smooth and there's no wrinkles or folds. Now these connect on to this. One end has this metal piece. This connects to the machine right here. And this piece connects onto these two. And you just kind of cram them on there, really. All right. Now with our blood pressure, we have a top number, a bottom number, and a third number. The top number is called systolic. The bottom number is called diastolic. The third number is called the MAP, or mean arterial pressure. That MAP should never drop below 60 millimeters of mercury. If it does, perfusion is compromised. What that means is, think of perfusion as like when you take a kitchen sponge out from under the sink and it's all dry and hard. When you run that under the water just kind of runs right off of it. You have to sort of work that sponge to get the water back running, squirting through it. That sponge would now be perfused. Kind of like that. Perfusion is how much oxygenated blood is getting into the organs, into the tissues. So if their blood pressure is too low, their kidneys and things aren't being perfused. So we need to make sure that that MAP stays above 60. Okay, the next monitor I'm going to put on is the temperature probe. Now you can use a regular thermometer for this and just leave it in the rectum, or you can use one of these. These are pretty nice because you don't have to take a temp every so often, it just constantly reads it. So this only has one place it can go, which is right here. And my probe, this would go, there's a long white piece that I'm not locating right now, but the long white piece would either go in the rectum, make sure you use lubricant on that, or you can put it down the throat. There's already a lot here, and this is a little guy, so this one I would place in the rectum. Okay. One more monitor that's not connected, the temperature should never drop below 96 degrees. If it does, perfusion becomes compromised. The body is trying to assess where the warmth should be. and it's going to assess, or it's going to prioritize those organs first. So we want to make sure that the temperature never drops below 96 degrees. This isn't connected to the monitor, but this is called an esophageal stethoscope. This part should look familiar, but this part's going to be new. This slides down their esophagus and sits right behind the heart. So we have to measure first. We'll find the level of the heart, lay this against their body, follow it up, and now I know that that's how far I need to push this in. So I'll slide this down the throat, and then I can just leave it there, and I'll set this next to my patient. When it's time to listen for a heart rate, I put the stethoscope in my ears, I listen, I count, I write it down, then I can just set this back down. So it just stays in place. Okay. With your EKG leads, they won't read just like this. You have to put something on them that's conductive. We typically will use alcohol. We'll just use a little squirt of alcohol on each one of the leads. But if you're doing laser surgery or something where you don't want flammable products, you can use ultrasound jelly on those as well. Okay, that's everything. So just a quick rundown again. The EKG measures the electrical activity of the heart. It doesn't tell you if the heart's squeezing or beating or how well that's happening. It just tells you the electricity that's running through the heart and in what pattern. That can indicate those things, but that's what it does. You need to wet those leads with alcohol or ultrasound gel. The white one goes on the right front. The left one is the black the black lead. Red goes on the left inguinal, and green would go on the right inguinal. If it's a 5-point lead and there's a brown one, it goes in the center of the chest. If it's a 12-point lead, that's a whole different thing, and you're probably working at a cardiologist. So that's EKG. This is the capnograph that measures the carbon dioxide in the blood, or in the breath, sorry. The inspiratory CO2 should be between 5 and 10 millimeters of mercury. The end tidal CO2 should be between 35 and 45 millimeters of mercury. And then it monitors respiratory rate as well. This one is your SpO2, or your pulse oximeter. This one measures their pulse rate as well as the percentage of oxygen in the blood. And then your blood pressure down here, your non-invasive blood pressure, the top number is systolic, the bottom number is diastolic, and the third number is the MAP, or mean arterial pressure. That should never drop below 60. The thermometer, it actually isn't reading for me right now, strangely. Let me see if I can get that to work. The thermometer would pop up down here, and it's not working. But the thermometer, the temperature should never drop below 96 degrees Fahrenheit. Okay? The capnograph connects here between the breathing circuit and the endotracheal tube, goes your capnograph. I talked about those. Your blood pressure cuff can go between the knee and the ankle, or between the elbow and the wrist. Make sure that the correct side is towards the patient, and you don't want to put it on too tight or too loose. And think about this too, if your patient is getting IV fluids, which they almost certainly are, don't put it on the same arm as the IV catheter, because when it squeezes, it's not going to let that fluid in, and you're going to get a lot of alerts from your alarms and things. So there's my blood pressure cuff, and then my temperature probe could either go rectally or down the throat. And finally, my esophageal stethoscope, which would go down the esophagus and allow me to listen to that heart. I think that's everything. Please let me know if you have any questions.